afternoon. It's a pleasure to be here with all of you. And I thank the organizers for giving me this opportunity to share my views on embryo cryopreservation. So two things that we need to keep in mind when we talk about embryo cryopreservation is that the nature of water. We know that water forms into ice crystals below 0 degrees centigrade, and the glass transition temperature of water is below minus 130 degrees centigrade. So when we do slow freezing, what we're doing is exposing cells to cryoprotectants, permeable, non-permeable, and then dehydrating the cell as the cryoprotectant goes into the cell and replaces the water. And then we initiate this rate-controlled drop in temperature. We seed at -7, start ice crystal formation in the extracellular compartment, and that dehydrates the water around, and the osmolarity increases, further dehydrating the cell. And then as cooling is going down, we are vitrifying the cell in the whole process. So slow freezing has been in vogue for a long time for early practitioners like me. But our aim is to always have intact embryos after cryopreservation, and ice should never be allowed to appear and grow inside the cell. So things were not so great. We were dealing with chilling injuries, we were dealing with osmotic damage, fracture, and somehow survival was lower, around 60 to 70%, like we saw very early from the Alpha Consensus on the cryopreservation KPIs and benchmarks that was published in 2012. And if you look here, our freezing and vitrification did drastically different. The competence and benchmarks for slow freezing being on the lower side when compared to vitrification. Today, our benchmarks and even competence has grown to around 99 to 100%. Things have changed drastically in vitrification. So we moved because we needed to be better. We needed to offer couples better outcomes. And so vitrification came in the early 2000s, where it just caught on, where what is this vitrification? We are actually, it's an ultra rapid method of cryopreservation where the embryo is transiting from very fast from room temperature to minus 196 degrees centigrade in liquid nitrogen in less than just 1 second. And this rapid drop in temperature, what happens is that this rapid drop in temperature pushes the cell into the glass transition temperature of minus 130 without so fast that we are eliminating the process of formation of ice. And this reduced all the problems that we had faced in slow freezing, with better outcomes, better survival, and better implantation rates. And this is the basic fundamental thing that we used. We increased the viscosity of the cryoprotectants. We increased the speed of cooling. We lowered the volume of the cryoprotectant around the embryo, the media around the embryo, and we did not allow the ice formation. We did not allow liquid to solidify, and we actually moved the liquid into keeping the molecular organization of the liquid and moved it into a solid glass-like state. So there are three variables. One is the rapid cooling and warming, the concentration of the cryoprotectant, and that minimal volume that Kuwayama, allowed us to use and gave us this beautiful concept of low volume, where there was direct contact of the cell with the liquid nitrogen with very minimal volume on the device. And that rapidly increased the cooling rate, and that actually made survival so much better. So vitrification caught on, and all of us definitely, we all know that the endometrium behaves differently. The genetic profiling is different when stimulation happens, when hormones are used, when multiple follicles are generated in IVF. And somehow the implantation rates were poorer and lower compared to the frozen cycles. We also knew that there were better outcomes with frozen cycles. And several problems during stimulation could be overcome by freezing embryos, like elevated progesterone, ovarian hyperstimulation, and of course, we know that PGS requires freezing. So looking at this scenario, cryopreservation through vitrification caught on, and we moved from that scenario where we were freezing many embryos to today where we're freezing single embryos per straw and offering couples a higher outcome, a better outcome with the cumulative pregnancy rate going up because we are doing multiple attempts, keeping the safety in mind. So it can be done at different stages, and which is ideal. So what is the ideal stage to vitrify? We have a lot of reports showing that, comparing that the cleavage stage to the blastocyst stage, and several reports favor blastocyst, some favor the cleavage stage. Looking at this meta-analysis by Zeng et al., what we are looking at is he looked at these various studies, big powered studies that are, published recently. And the clinical pregnancy rate, when we compare blastocyst to the cleavage stage, favoring blastocyst in most. When we looked at the implantation rate, favoring blastocyst again in all these studies. When we looked at multiple pregnancy rate, either it was in the center or favoring cleavage. When we looked at the ongoing pregnancy rates, both did similar. When we looked at the live birth rate per transfer, also similar, but maybe favoring cleavage. But that was argued that, because maybe we are offering blastocysts to only that segment of population that didn't do well or had multiple failures, and probably that data was a little, altered. So the optimal stage for embryo vitrification remains to be determined, but blastocyst stage vitrification does have advantages. Blastocyst transfer results in higher implantation, better clinical pregnancy rate compared to the cleavage. And extended culture also synchronizes the embryo to the endometrium better. And we also know from Munne's work that the chromosomal abnormalities were lower in the blastocyst compared to the cleavage stage embryo transfer. There are some limitations. Cancellation rate could be higher. Blastocyst transfer is associated with higher monozygotic twinning rate. And there are articles that showed that, both are the same. And also maybe blastocyst transfer contributes to epigenetic mutation in the offspring. So looking at a lot of meta-analysis, a lot of data put there, undoubtedly blastocyst transfer remains the favorable and promising because of the higher implantation and implantation rates and, compared to the cleavage rates. Probably the reason is high survival, lack of ice formation, and important point to remember is that the blastocele cavity has to be small, and artificial shrinkage on fully expanded blastocysts or day 6 blastocysts is something that we have to keep in mind when we're doing a blastocyst vitrification. Now, there are articles by, there's work by Tong that says that, blastocyst culture and transfer should be offered primarily to younger patients less than 35 years of age in tandem with vitrification. So the data definitely showing us that you can freeze at various stages, but blastocyst does better, probably because of the permeability of the membranes. Look at how, early cleavage embryos are doing. Just permeability is happening with the cryoprotectants, and water is going out of the cell by a process of simple diffusion. Whereas if you look at blastocysts, morula and blastocyst stage, we already start having these gap junctions and channel diffusion is adding on. So that is improving outcome maybe. Different cryoprotectants behave differently also. And also the cell size and surface volume ratio also plays a key role in this exchange and giving us better outcome. Now, what are the factors that influence survival? Age of the woman, definitely her response, the stimulation that you're using, the number of oocytes that you get, the quality and the maturity. We know of this beautiful concept called ovarian sensitivity index, where the ovary and the follicles that are responding better to stimulation and getting higher numbers of oocytes give you more euploid embryos than those ovaries that are responding slowly or with great resistance. So we know that IVF is very different, oocyte quality, dysmorphisms, a good synchronization between the cytoplasmic maturity and nuclear maturity is extremely important to create great embryos. So we're always exposed to this problem of dysmorphic oocytes when we do IVF, and that probably, we don't know the origins. They probably have downstream effects, as we go down the culture to day 5. So sperm is important. It plays a role too. It's important to select and pre-treat the male. Our lab culture conditions play such an important role in creating great embryos. We cannot forget our basics. KPIs have to be maintained. The pH, temperature, osmolality, the VOC, the air quality are primarily the most important features in a successful cryopreservation program. Now, moving on, we have to select the best embryos during freezing. Different quality is different survival. Damaged embryos have lower potential. Resumption of mitosis post-thaw is an indicator to pick the best embryos post-thaw. And as I said, artificial shrinkage is to be incorporated when you are freezing, vitrifying large blasts. Now, this beautiful article by Laura Rienzi's group looked at single embryo transfers, all blastocysts, from 2 centers, tested, euploid, untested, and what they saw was if you had the live birth rate, they looked at live birth rate and they saw that in untested group, the blastocyst transfer, the pregnancy rate, the live birth rate was 26% compared to the euploid blastocyst transfer 40%. But more importantly, what you saw, look at the scoring that they did, the degeneration score and the re-expansion score. Here is a blast that re-expanded maybe in 2 hours, 4 hours. Here, it was partially re-expanding. They did not re-expand at all. And what is interesting is, that the poor quality blasts, 92.5% of them survived, but the live birth rate here was only 2% in the untested group and 7.3% in the tested group. So embryo selection and treatment is an important factor that, can change the outcome for your patient. I believe that every clinic should have a freezing policy. You must have strategies in place. Every member of the staff, every member of the team working should know which day, which stage to freeze, how many to select, what to select, how many embryos per straw, and have a strict policy in cancellation, a robust embryology counseling. And we must not do any pity freezing, because if you freeze poor quality, your outcomes are going to definitely be affected. So our freezing policy is we freeze at the morula stage on day 4, or at the early blastocyst stage, late day 4. We thaw and culture for 6 hours and do a transfer, or we put the embryos for an overnight culture and select blastocysts for transfer. This we have been doing for the last nearly 10 years. And when do we offer day 5? Only to those good responding patients who require single embryo transfer or previous IVF failures. We freeze blastocysts on day 5 or day 6. And for me, freezing on day 3 is a bit confusing, because this is typically what you see under the microscope. So it's difficult. Whereas on day 4 gives you so much more clarity, and you freeze less. I freeze only 2 per straw. If I have slow embryos, maybe then 3. But this is how we freeze 2 embryos, in each straw. And blastocysts are frozen singly. And this is how we distribute our embryos. The process that I use is to leave the embryos for 5 minutes in ES and wait for re-expansion. And then when I pick up the embryos and put them in the VS, I only pipette them in the VS. I don't leave the embryos. I leave them on the top, go to the top, go down to the bottom, pipette the embryos in and out, less than 30 seconds, place them on the cryolock, withdraw all the media completely and make sure that just the embryo is popping up there. And post that, I like to kind of run it through to move the device continuously so that whatever vapor is there is eliminated, and there's a direct contact between the embryo and the liquid nitrogen to give you that fast cooling rate that is required. So here are the events that happen in the ES. First, dehydration, the cryoprotectant is going in, water is going out, and then there is, the embryo recovers. Now, vitrification allows you to observe the embryos throughout the process. The non-viable embryos, like here, they don't shrink completely in the ES and VS. And these are the embryos that they really don't do well, and you can keep them aside and maybe, this embryos generally, that's my observation, they don't really do well. The warming is, this is how it's done. We bring the carrier out, and that's, I keep a large drop of 1 monad at 37 so that we keep that temperature going. And then for 1 minute, and then 2 minutes in 0.5, 2 times, and MOPS 3 minutes, 3 times. So here are the events that are happening, and the embryo comes back beautifully. Survival is near 100% at these stages, and I have been doing very well. This is the cryolog that we use, and I feel that the pipetting of the embryo in the VS, I'm keeping 0.1 ml on the carrier and doing this whole thing within 30 seconds is one of the key to success. Survival is more dependent on the warming rate because ice crystal formation is entirely eliminated in vitrification, except for that short transitional freezing of the solution during warming. And therefore, we must use that large volume drop to keep it at 37 and thaw at room temperature. What I like to look at immediately is the integrity, and then over time, we look at the progress and select embryos for transfer. So post-thaw, if the survival is of the ICM is less than 85%, we do know that implantation potential is compromised. Re-expansion normally should happen within 2 hours. So it doesn't really matter which which media you're freezing in and which you're thawing in, because we know that they are all nearly the same. But we would like you to choose the cryomedia which is close to your base media to minimize stress on the embryos. And this beautiful article showed us all that whether you freeze in Kitasato, thaw in Kitasato, freeze in Kitasato, thaw in sage, or whatever the combinations, they all do the same. And it's an important thing, take home message, because now embryos are moving from clinic to clinic, and you can really use whatever works for you in terms of the thawing process. You need not actually keep the media as the same as what was used for the vitrification, and it simplifies our routine. So it's important to keep in mind that during embryo storage, we're keeping very, very little volume of the media around the embryo, surrounding the embryo. So any shift can change things and outcomes, and therefore we need to top up the LN2 and every day. And here are our IVF results with our frozen embryo transfer. I leave you with them. We've been consistently doing pretty okay from 2016. I put them down here. The last 6 years, the clinical pregnancy rates in our FET transfers. I thank